My name is Rick Greene, and it is my great pleasure today to serve as your moderator for this video interview that will be part of our celebration for the 100th anniversary of the Commission on Cancer. And part of that celebration is to interview past CoC chairs. And it's my great honor and privilege to interview Dr. John Niederhuber, who was CoC chair in 1989 to 90. So John, welcome.
Glad to be here, Rick.
So let me just start off by asking you. You actually were a member of the Commission on Cancer beginning in 1983, and obviously did so much for the commission. I wonder if you could tell me how you got involved in the commission. How did that happen?
You're testing my memory. I believe I was a delegate from one of the organizations, but to be honest with you, Rick, I don't remember which one. I know that I served on several committees for the commission, and then was vice president a year, and then president for a year.
Right. Well, it's interesting that you bring up the member organizations, because the CoC is now up to about 58 or 59 organizations, and I myself first got involved by representing the AJCC in the Commission on Cancer. So I know how valuable that is. So I want to thank you. You know, you were CoC chair, though, at a very interesting time, because the National Cancer Database was developed in 1988, 1989. I wonder, John, if you can just tell me your impression and what value the NCDB brought to cancer care in the United States.
Well, as everyone knows, one of the great activities of the commission was the certification, review and certification of various hospitals across the country delivering cancer care. And the concept that we had was to maximize or optimize that care and the outcome for cancer patients in these various centers. Not all of them were what we would call national cancer centers, NCI supported cancer centers. Many of them, in fact, I think the majority of them back in those days were really community centers that had dedicated resources and an organizational infrastructure to supporting outcomes, excellent outcomes in cancer care. And then out of that, or a part of that, was the development of an outcomes database, that is, incident cases that were seen at those hospitals. Part of their qualifications for certification by the college and by the Commission on Cancer was the keeping of a database. It was in those years, in the late 70s and 80s, as I recall. Rick, you probably know this history better than I do, but the evolution or development of cancer registrars, and I think the college probably had a lot to do with fostering that or putting an emphasis on that. So there was this sort of underlying infrastructure brought about by the commission as part of its review processes for these hospital entities that were delivering cancer initial diagnosis and cancer care, that the idea or the concept came about. Well, what about creating this national database? And what kind of a resource would that be? My recollection is that Glenn Steele had a great deal to do with that. He had a lot. Glenn has a big voice and placed a lot of emphasis on this concept. Like so many new things, there were some skeptics. As I recall, the discussions weren't about developing this and about placing the necessary resources behind it, weren't always smooth. There were some people who felt that this was more an undertaking that was more than the commission should be involved in, but others were very, very supportive of it and the concept. I think the story in all of this is the results, I guess, over the years. And I remember this past year reviewing a couple of manuscripts for a prominent journal in which that database had been used prominently in the analysis by the investigators. And it was very clear the value that the National Cancer Database has achieved over all these years. So like any good project, this has grown and achieved national and international stature as a database resource for outcomes research.
Well, it's so appropriate that you bring up the manuscripts generated. We're going to actually feature outstanding manuscripts during this 100th anniversary that used NCDB data. So I'm so glad you mentioned that.
And
so
I suspect, Rick, that and you probably have those that data or those numbers, but I suspect that number or that curve of publications using the NCDB is increasing on a yearly basis.
Absolutely, it certainly has. So John, let me ask you, you went on to become an NCI director at the University of Wisconsin, their Comprehensive Cancer Center. And as you know, you mentioned how important it is for all hospitals to be involved, but tell me a little more. Why should the NCI core comprehensive cancer centers be involved in commission activities?
Well, it's an important question, Rick. In fact, you know as well as anyone that many of the cancer centers, that is the NCI designated cancer centers, research university-based centers, didn't feel a necessity to be involved with the review process that the Commission on Cancer has, and opted out, just avoided being part of this national program. It was never quite clear to me why that was the case. The arguments never made a lot of sense to me, but you know as well as I do, there were very prominent centers that did not elect to participate.
Well, we're happy, of course, that the majority of our NCI core comprehensive programs are members of the commission.
But that took some time, as I recall.
Yes, yes. You, of course, went on to become director of the NCI in 2006. And I wonder again, from that standpoint, maybe you can tell me, were there things that you learned through the CoC that you took to the NCI or took to that level of cancer care in the United States? And maybe from that 30,000 view, how does the CoC really fit into cancer care in the United States, in your view?
Well, I think probably the lessons learned would go back to the sort of nature of the Commission on Cancer that you mentioned earlier, Rick, and that is the number of organizations that were involved in those days are involved today by sending representatives. So really the Commission on Cancer was an organization that covered a lot of the various cancer advocacy community, and also obviously the different specialties involved in the care of the cancer patient. So perhaps that background, that experience was valuable in being the NCI director. I can't remember the exact number, but I remember saying one time in I think a news interview that I had 60 some advocacy groups that constantly were knocking on my door as NCI director with one cancer or another. And I think, I don't remember how many, something 2 or 3 in prostate and 2 or 3 in breast and so forth. So there were a lot of people that had a voice and an opinion. But clearly, the commission prepared me to have a good understanding of the importance of this advocacy community. It also influenced me perhaps in a different way, and I'm sure you are aware, I, during my directorship, pushed a program called for community cancer center support. This was a new idea for the NCI. I can tell you I took a lot of flack for this endeavor. There were a lot of people who felt that I was spending money that should be going to research grants and not to fostering an expansion of cancer care in community environment. But I felt that it was very important to bring the influence and the weight of the National Cancer Institute into the community setting, to influence the collaboration of the various specialties in the care, in the diagnosis and care of the cancer patient. I felt that the cancer centers funded by NCI weren't doing as much in that area as I felt they could. And again, the various directors of these institutes didn't feel that I was on the right path, but I'm still proud of having started that program. Some remnants of it continue to this day, and I'm proud of that effort.
Well, I'd like to think that your 2 years as CoC chair and all of that wonderful experience spawned all of those things that you did at the NCI.
I'm sure they had an influence.
So John, finally, I want to ask you, what are you doing today?
Well, in April of 2019, I decided that it was time to step away from a full-time employment. So I did so, and since that time, my wife would tell you I've been busier than I was before I stepped away. But I have an adjunct professorship at Hopkins, where I spent some time on the faculty in the past, and as part of that responsibility, I mentor several young people. I am actively involved in the surgical oncology training grant that Hopkins has from the NCI. I helped them rewrite the renewal of that grant and restructure some of the educational components of the grant. And so we got that successfully renewed, and we've just taken on 3 new fellows that will start this coming July. We just finished that interview process and selection process. So I'm involved with the Department of Surgery and the surgery chair, as well as the leadership on this training grant, which is also has involvement of the Cancer Institute at Hopkins. And then I serve as deputy director of the Johns Hopkins Clinical Research Network, which involves a number of health systems outside of Hopkins as a network capable of doing clinical research, clinical trials, and writing grants for funding from the National Institutes of Health as well. So those
Well, I
are the
have to-
main things. Then I have a few boards that I serve on and involved in the NIH Oxford Cambridge program and things like that.
Well, I have to agree with your wife. You're probably busier than you've ever been. So, John, I want to thank you not only for your past as being a CoC chair and everything that you've contributed to surgery, because we're both surgeons, as well as to cancer care in this country, but also for what you're doing now in the next generation for cancer care. So, John, thank you for being part of this video interview series.
My honor, Rick. I'm pleased you would ask.